Hi folks, this is Dr. Rob Cywes. I am the Carb Addiction Doc, and more, and appropriately so, people are worried about cardiovascular disease. People are worried about dying of a heart attack and a stroke. And yeah, it's appropriate because more than any other cause of death, heart attack and stroke is the commonest cause of death in this country, the United States of America, and rapidly becoming so elsewhere. So today's discussion is going to be what alternatives are there to statins, to effectively reduce my risk of plaque, to effectively reduce my risk of a heart attack and a stroke that doesn't involve the side effects of statins. And quite frankly, statins have little to zero value in terms of protecting you from the heart. Oh, it's anti-inflammatory. BS, it's not. So first thing is, as a strategy, as a mental concept, there are two polar opposite ideologies. The inappropriate, ineffective, tobacco company, industry-driven narrative that has no 000 scientific foundation is that cholesterol and fat and LDL causes cardiovascular disease. That is a false narrative, okay? Cholesterol is part of the response system, of the cleanup system, but it does not and never will and has never caused cardiovascular disease. It's evident in the healing process. So what does cause it? One word: inflammation of the cells that line your blood vessels, inflammation of arterial blood vessels. Not veins, not capillaries, inflammation of the arteries that supply blood to the system. Period. End of story. And when we look at inflammation, there are three major triggers of inflammation, and then the response to that inflammation is a singular response that is a stepwise classic human response. So if you have inflammation caused by these three or four things, the way the human body responds is in a predictive way of creating a fibrin clot, a cellular clot, and then laying down cholesterol afterwards. So the cholesterol is present, but it's a response, not a cause. Okay? So understand that. So anybody who ever mentions the word cholesterol in connection with plaque causation doesn't understand human physiology and has bought into the big tobacco lie. And I'm very adamant, I'm very categorical about that, okay? And even cardiologists are shifting. So let's talk about inflammation. There are significant causes of vascular inflammation that potentially the majority of them are caused by you yourself to yourself. And then you're triggering your body's response. The first historical one is nicotine. Nicotine causes a particular pattern of inflammation in the lining blood vessels of your arteries. And I'm going to discuss the difference between nicotine and what's now become. So nicotine rates have declined, although vaping is increasing. And yes, vaping as much as smoking, despite what the tobacco companies tell you. If you trust them, just switch this channel off now. Okay, if you trust the tobacco companies and them telling you that vaping is better than smoking, just go away. Nicotine causes that inflammation, and we've seen a bimodal. We saw smoking decrease. Now we're seeing vaping increase again. The second one, which is actually now universally the most common one, is chronically elevated glucose levels in the bloodstream. Chronic hyperglycemia, elevated blood sugar, is also a very, very pro-inflammatory molecule of those arteries. So nicotine and carbohydrates are those two molecules. Now, there are a few more, and we'll come back to that in a second. One of the key things, and we've been kind of debating this amongst a group of folks that are interested in the same topic, is that there are guys like Malcolm Kendrick, who I respect tremendously. He wrote a beautiful book called The Clot Thickens, but Malcolm believes plaque is plaque. And I completely disagree with him. As a surgeon, as a physician in clinical practice, there is a big distinction between plaque caused by sugar and starch and plaque caused by other modalities, particularly smoking. And that is in the distribution of the plaque. So nicotine causes inflammation in arteries well beyond the coronary arteries. So yes, the coronary arteries, the arteries that feed the heart, those are the most dangerous ones because that's where you have your heart attack, your stroke. So both nicotine and carbohydrates affect those coronary blood vessels, and we get plaque in those vessels that both for smokers and for hyperglycemic carb addicts will result, or diabetic type patients, diabetogenic patients, will cause that plaque in the heart. Sugar typically, glucose typically does not in a dominant way affect other blood vessels. And this is very important to understand. Very important to understand, even in non-smokers, because you've got to look elsewhere. So sugar does not, in a dominant way, affect the peripheral blood vessels. I'm not sure, I don't have an understanding of why it's just the heart, but the carotids, the brain bloodstream, the descending aorta, the kidney vessels, the peripheral vessels, peripheral arteries, not heavily affected by elevations in sugar. The liver blood vessels, the sinusoids, tiny little capillaries, the capillaries in your legs, in the nerves, which are fed by bloodstream, yes, affected by hyperglycemia. So elevated blood sugar affect fine little nerves, increase the risk of clotting in the veins, not plaque, and then primarily affect the heart. Whereas nicotine, and I don't understand the mechanism completely, but it's a different mechanism, primarily affects the entire arterial system. The entire arterial system doesn't have that profound effect on the microvasculature. Will have an effect on the smaller arteries down to the feet, so you can get claudication and that kind of disease. But it's an arterial trigger for inflammation, and you can get plaque in your carotids, you can get plaque in your vertebral vessels that can cause strokes, you can get plaque in the aorta that causes aneurysms. We don't see aneurysms that much in diabetics, at least in terms of the aorta. Can affect the arch of the aorta, can affect the kidney vessels, and then the peripheral vessels. Different pattern and a different disease entity. So it's important to differentiate between those two. Now, in someone who used to smoke and maybe quit smoking and went to sugar, you see the crossover. So I've got a number of patients who are in the 50s, 60s, 70s who have plaque. They may not have elevated blood sugars, but the plaque is still a residue of their smoking days. Remember in Vietnam, in the Vietnam War, where the average age of those soldiers was 19 years of age who died. The average age of death in Vietnam was 19. The majority of those soldiers smoked, and the majority of them already have evidence of plaque in their peripheral vessels, even though they were only 19, from nicotine. So it occurs early. It occurs very early, okay? So what else do we have to look for? So if I'm looking at someone who's diabetic or has hyperglycemia, I'm going to look primarily at the heart. If I'm looking at a smoker, I'm also going to look at the peripheral blood vessels. But if I see peripheral blood vessel disease, if someone's had a stroke, if somebody's got peripheral vascular disease, and they've never been a smoker, there are a few other causes, much more rare, but very important for clinicians to look at. And if you're one of those patients, demand that your doctor looks at this. The first one is genetic vascular autoimmune disease. And if you have genetically a propensity for autoimmune disease, and you can test for that, that may be a secondary complication of vascular disease that can occur in the heart, but also peripherally, even if you've never been a smoker. So hyperglycemia plus autoimmune disease definitely accelerates atherosclerotic plaque deposition peripherally as well as centrally. And the worst one is lupus. So for those folks that do have lupus, you should, in my opinion, be on an anticoagulant, reducing clotting, reducing that plaque, and obviously on a low carbohydrate diet. We'll come to the therapy in a little bit. But lupus is one of the worst ones. But if you've got other forms of autoimmune disease, and in particular, if you have a high ANA, anti-nuclear antibody, or rheumatoid factor, and those are two easy ones to test for. We routinely test for that in the blood. If your RF is significantly positive, not just mildly positive, and your ANA is significantly positive, you are at higher risk of vascular plaque disease. Sjogren's syndrome. There are other autoimmune diseases that increase vascular inflammation peripherally. And then the final one, there are others, but the four dominant ones: carbohydrates, nicotine, autoimmune disease, the lupus antibodies. And the final one that I look for, and I've realized this because I see so much blood work in my clinical practice, is chronically elevated uric acid. Uric acid, and Ben Bickman and myself have both done talks a few months ago on uric acid. I'd urge you, if you've got high uric acid, to go back and look at those videos. But uric acid specifically is a pro-inflammatory molecule of the blood vessels. We associate uric acid with gout and kidney stones, but it is a prime independent trigger of inflammatory vascular disease. And we have a subset of patients who have a family history of high uric acid. Now, uric acid can come from fructose, it can come from protein waste, it can come from purines and pyrimidines. So all these people taking ribonucleic acid, RNA, or extracts of RNA, look at your uric acid. If it's elevated, stop taking that as a supplement. How do I know that? Because I've seen it in clinical practice. I've seen it in several patients. It's a trend. I don't have a peer-reviewed publication, but the purines and pyrimidines will cause an elevation in uric acid. So will unprotected high levels of protein. Remember, in reptiles and birds, uric acid is their primary protein metabolism pathway. We in humans use BUN, which is more liquid soluble, blood urea nitrogen. But if you're processing protein to energy, you got to get rid of that, and uric acid is a protein waste. And then fructose is the commonest one. So if you have a genetic predisposition to chronically elevated uric acid, be aware that you are at risk for vascular disease. So those are the four risk categories. Now, how do we mitigate risk? Well, obviously, number one, don't smoke. Don't smoke. Because society's become antagonistic to smoking, and to a certain extent vaping, it's easier to get rid of smoking, but I know it's still damn hard to do. But if you care to change, work on your nicotine reduction or elimination. Get rid of nicotine. Nobody needs to do that. Okay? It's kind of bizarre for me that knowing all of this, we still sell cigarettes and nicotine in this country. That's the econo-political bullshit that we have to deal with. Anyway, the second one is a ketogenic diet. And if a ketogenic diet at first, ultra low carbohydrate, high fat diet, is not adequate to reducing your blood sugar levels, because the system is broken and the system doesn't fix itself in a few weeks of not eating sugar. It takes up to 2 years, folks. Sometimes a buddy of mine in the space, Marco Casella, mentioned that it took him 4 years as a diabesogenic person, big time runner. Mark took 4 years to become fat adapted. So this is a slow correction. It's a slow process. I typically quote about 2 years. And if you need help along the way, I would strongly urge you, especially if you in your 50s and 60s, where you don't have the wiggle room, the luxury of time, I would strongly urge you to use medications for a while, for a short while, to steepen the curve, to accelerate your rate of keto adaptation, to accelerate fat adaptation. And the commonest drugs there are the GLP-1s, but there are other medications that can help you to correct hyperglycemia quicker than you can do with diet. If you're 20 or 30 or a teenager, that you've got the luxury of time. But once you've already got significant heart disease, don't screw around, okay? So the two foundational things that you can do is, number one, quit smoking. Number two, get on a ketogenic diet, a high-fat, low-carbohydrate diet. And if you eat a lot of fat, if you've got high uric acid, your fat percentage, your fat ratio should be very, very high to protect protein from contributing to uric acid. And don't be taking any nucleic acids as supplements, which there are flapping gum people with very cool stories to tell you, oh, you need to take RNA, you need to take ribonucleic acid. Please, please, please don't do that, okay? So monitor your uric acid, monitor your blood sugar, and there's devices, the G7, Dexcom G7, there's the Sibio system. Now Dexcom is coming out with Stello. Those are the more accurate systems. There's also the Libra systems. They're coming up with Rio and Lingo. They're good enough, but they're not as accurate as the Dexcom systems, in my opinion. However, monitoring your blood sugar and then going on a ketogenic diet, very, very important in terms of stabilizing and reducing coronary artery vascular disease. So having said that, what strategies, what alternatives to statins? Because as soon as your cholesterol is high, irrespective of your cardiovascular status, and this is the BS, there's a knee-jerk by the majority of doctors, PCPs, and definitely cardiologists still, who haven't adopted the inflammatory model. They're still trapped in the cholesterol model. As soon as they see an elevated LDL or an elevated cholesterol, the automatic emotional knee-jerk is to put you on a statin, and it causes havoc in terms of side effects and complications your body doesn't want. And it is absolutely, by evidence, ineffective in terms of helping you to reduce your risk of a heart attack or a stroke. And all you have to do is be logical. Right now in 2024, more people are on statins than ever before in our history. And yet, more and more people have heart attacks and strokes. Think that one through. If statins were supposed to reduce risk, surely we should see a decline. Okay? Just be logical about that. Okay, but remember that statins were initially developed to combat the plaque from nicotine. They were developed in the 70s and 80s and really started becoming popular in the 90s, where we saw nicotine cardiovascular disease at its highest, 70s and 80s. And we were just starting to see the rise of carbohydrate-related cardiovascular disease. So statins were developed for the smoking industry. And now we've surrogated it across to the carbohydrate industry. And that's why cardiologists struggle to understand the concept of hyperglycemia. Although now more and more, they're starting to understand that the majority of patients I'm seeing right now with cardiovascular disease are diabetic. And diabetes is not caused by fat and it's not caused by cholesterol. It's caused by sugar. So they've still got that cognitive dissonance that they're trying to sort through, let go of the smoking era, now trying to adopt the diabetic era and using diabetic medication rather than the other. So the first thing, no matter who you are, if you are interested in your health, more so than anything else, the first thing I would recommend is a screening test called a coronary artery calcium score, a CAC score. It's a CT scan of your chest, gives you peripheral chest information, but primarily tells you, am I at risk? And the thing about the CAC score is it's binary. It's either positive or it's negative, and I use around 80 as my positive number. If you're above 80, you are at risk. If you're below 80, your risk of a heart attack or a stroke because of plaque is very, very low, and you don't have to do anything about it. Okay? Oh, it's soft plaque. Yes, there's some noise, but I've got a 0. If it's a 0, I don't care what your cholesterol is, especially if you're in your 40s, 50s, and 60s. A 0 means that you don't have any coronary artery calcium disease of significance. You can still get clots, but you don't have plaque that is going to narrow your blood vessel to the point that you get ischemia of your lack of oxygen to your cardiac muscle and have a heart attack because of plaque. Okay? If your score's above 80, the next step is to go ahead and get a nuclear medicine stress test to see if it's affecting your heart. If it's not affecting your heart, if the nuke med stress test is negative, I would stop there, adopt the strategy we're talking about, and retest in about a year's time. Because what you want to do, the key thing about CAC score, if it's positive, it's above 80. I don't care if it's 3,000 or if it's 200. I don't care how positive it is. What matters then is whether or not the CAC score is level over time or whether it is going up by more than 20% per year, year over year. Your risk is primarily, once you've got risk, which is a positive CAC score, the increasing risk year over year of having a heart attack is based upon the rise in the CAC score. That's very, very important. And I've had a discussion on this channel a few weeks ago with a guy by the name of Phil Avadia, who's a cardiovascular surgeon. We discussed this in detail. So looking at if you've got a baseline number, look at the trend. Am I flat? Am I going up? Those are crucial bits of information. Now, if you have a positive CAC score, whether it's going up or whether it's flat, the first thing to take, unless there's a contraindication, is an 81 milligram aspirin a day. Why? Aspirin does nothing for plaque. Aspirin doesn't do anything for plaque, but the plaque is a rough surface area, and all the time in the human body, in our blood vessels, we are forming little fibrin clots to heal up injury, to respond to minor bits of inflammation in different blood vessels. If you've exercised, whatever it may be, we form little clots, but then we've got a clot dissolution, a thrombolytic. Lytic means lysis, means breaking down of clots. So we form clots, we break them down all the time. And that's just the little fibrin or the protein clots. Once those clots activate cells, and the first cells that they activate, you can call them cells, I do, are platelets. Not true cells, but they're breakdown products of a cell called a megakaryocyte. When platelets become activated, that is the transition point that affects thrombolysis. If you don't have a lot of platelets trapped and they're not activated, you can lyse that clot. If the platelets are there, the clot tends to become more chronic and more permanent. Those platelets attract white blood cells. White blood cells get activated. They attract macrophages, and macrophages attract the cholesterol. Okay? And you can never, ever reduce your cholesterol to zero. Therefore, you can never, ever avoid or reduce plaque because you deal with cholesterol. You cannot have a cholesterol of zero. I have actually seen that bizarrely, and that's in a very, very difficult situation because cholesterol is necessary for the body. But you cannot. So it doesn't matter if your cholesterol level is low or high on statins. It's not going to affect the plaque evolution. Okay? If you've got a lot of spackle or a little bit of spackle in your bucket, you're still going to heal up the holes in your wall. Same thing here. So it's illogical to address cholesterol. However, if we disrupt the acceleration of the clotting cascade and we disrupt it at a cellular level, we enhance the lysis, we enhance the breakdown. And what aspirin specifically does, thromboxane A2 for the nerds, what aspirin does is it blocks platelet or reduces platelet activation so that the clot is more likely to be dissolved than stay and propagate. And that's why aspirin, which is very safe, unless you've got a bleeding issue, and it's a global anti-inflammatory, so it'll help your sore joints, it'll help your headaches, it helps a variety of other inflammatory things. Aspirin has always been used as an anti-inflammatory, but in particular, it reduces clotting. The second drug, and think about what I said about uric acid, the second drug that affects and decreases white cell activation. So you've got thrombin, platelets, white cells, that affects white cells, white cell activation, is a drug called colchicine, colchine, originally developed for gout for uric acid. You see how everything's connected? And if it affects the uric acid, it affects white cells and people who have gout and know colchicine pretty well. But it reduces the inflammation of a gouty attack, reduces the risk of kidney stones from uric acid, but it is a white cell blocker. You've got to be very careful with the dosing, If you overdose, it can actually kill you. So you've got to be very cautious. Don't be a more is better kind of person that we see a lot in the ketogenic space. But at an appropriate dose of around 0.3 to 0.5 milligrams daily, it together with aspirin is very, very effective. And you don't have to use a statin. The papers were done in conjunction with statins, but the statin element is irrelevant. The colchicine is a very, very important drug. Now, when do I use colchicine? Well, the other thing you want to ask your doctor to do is test your inflammatory markers. And there are a few particular molecules that are associated with inflammation. The most common one that is used in studies is HSCRP, highly selective CRP, and C-reactive protein. And the C-reactive protein is a global marker of acute inflammation, and it correlates directly with your risk of forming blood clots. So HSCRP is a very useful marker. If your HSCRP is low, below 0.3, you don't need the colchicine. If you've got plaque, I would still use the aspirin. However, HSCRP is one of inflammatory markers. The other one is your white blood cell count. Unless you've got an acute infection, if your white blood cell count is above 5, I'd be worried about that. If it's below 5, you're okay. And especially you want to look at your eosinophils and your monocytes. Eosinophils and monocytes. If those are elevated, typically monocytes above 6%, eosinophils above 1%, then you also have a vascular pro-inflammatory situation. Ferritin. There are a variety of different reasons why ferritin is elevated, but ferritin is an intracellular marker of inflammation. And I look at a ferritin level of around 150. If there's no other cause, that is a cause for concern, especially in someone with plaque. So those are some of my inflammatory markers. And then obviously, we've talked about this, uric acid levels. Check out your uric acid levels, and it's worthwhile to do an ANA and a rheumatoid factor, your autoimmune markers, at least once in your duration. So have a look at those markers, and if those markers are positive, or if your BUN is positive, if your blood sugar is positive, all of those are markers of inflammation, and they should warrant thinking about anticoagulant medication. Now, the internet, the gum flappers on the internet, and I think there is a small degree of science behind this, but then we move into the economics where people are pushing this as a strategy because they're selling you the drugs, and I'm very, very opposed to that. And there are certain drugs that, yes, theoretically have a minor response. But to my mind, I don't think if you're on a decent diet, it is worth looking at these. But the ones I'm talking about, and I don't want to do a deep dive into the theory or the physiologic theory, but that's NAC, niacin, and vitamin C. And then there's a whole host of others that, and you'll always hear these sexy stories behind them. But if you are depending on NAC, niacin, or vitamin C levels or vitamin C pills to help you with plaque, you're as misguided, in my opinion, this is going to be controversial, as misguided and misled by those people promoting drugs, trying to sell you something, as the statin people. So please, I have no problem with you taking those, ancillary to the others, but don't make that investment because the hard evidence is just not there. And if you've got cardiovascular disease, don't just be using those because you don't want to take the others. A medicine is a medicine, whether it's a supplement or a medicine, a classic pharma medicine, it doesn't much matter. They're all additives that you're taking in pill form to prevent a disease that you caused. So vitamin C, I don't have a major issue with, but why? Get it from your food. So again, I'm not going to argue tremendously with people. If you want to take NAC, if you want to take niacin, and niacin makes you feel like shit, it did me when I took it 23 years ago, which is one of the reasons I started on this journey. But niacin, vitamin C, NAC, I have no problem with you taking those, but don't make the investment that they are going to save you from a heart attack or a stroke. They don't significantly diminish risk at the rate that you need if you've got positive plaque. And if you don't have positive plaque, you don't need them. Okay? But they are not substitutes for not smoking and a healthy diet. So please understand the difference between cholesterol and anti-inflammation and anticoagulation. We've got two things here. We've got anti-inflammation, your anti-inflammatories, which reduce your risk of plaque accumulation. And the anti-inflammatories stop activation of your immune system. So you want to dumb down quiescent immune system. Then we've got anticoagulation, and the anticoagulants block the propagation of clot, not directly but indirectly associated with plaque. Clot forms in an increasing percentage on plaque. So understand those two, and the medications that we've articulated so far have a dual function. They're both anticoagulants as well as anti-inflammatory molecules, in particular aspirin. And if that's what you're doing and you are monitoring your blood pressure, you're getting CAC scores, and you are monitoring your heart rate and your heart rhythm at home, you are set up for cardiovascular health. And if you want to consult, if you want me to help you, give me a shout. I am the Carb Addiction Doc, but we have strategies to help you better than most cardiologists. We use cardiologists to do the testing, but our strategy is most effective. Because I'm a metabolic health specialist. If you want to consult, 561-517-0642, call that, text that, WhatsApp that, anywhere in the world, and we will help you to create some direction uniquely by looking at your status. And if this channel has value to you, throw us a buck, throw us some coffee. Coffee's about $2 or $3 or whatever it may be. Throw us what you can to say thank you, but also to keep the content flowing and to keep it free. In the show notes, you'll see a Patreon account and you'll also see a PayPal account. Those are both toward our charitable organization at 501c3. Throw us $1. Thank you.